This conference will now be recorded.
Okay, this patient came to us for kind of a second opinion consultation to the pulmonary service, that is. She has already had a lung biopsy, a surgical lung biopsy for ILD, which I'll show you in a moment. I haven't had the opportunity to read the report of the surgical lung biopsy as described by the outside pathologist, but according to my clinical colleague, it wasn't very illuminating. But I will show you images from the pathological exam from my colleague here. So let's go and look at the CT. I'll start with this one, and I'm going to show you alongside it this one. This also shows you that there are places that still do rather unusual interstitial lung disease imaging. So this particular place does a combination, as you can see on the left, of 3 millimeter section thickness. And then here they do a limited number of, let me just bring up they do prone images, they do expiration. Give me a moment here. They do a limited number of, as you can see here, 32 images of 1 millimeter cuts at substantial intervals. I don't know why they do it that way, but I think most of us would do 1 millimeter section thickness contiguous throughout the lungs with a high spatial resolution algorithm. So let's take a look at these 1 millimeter section thickness images on the right. And how would one describe this? Let me just scroll through here first. Yes, it's abnormal. There is a peripheral subpleural process, not exclusively, but it's seemingly peripheral. And what words would one use to describe this? I would use ill-defined reticular, maybe ground glass, but the perfusion isn't that great. Let's go down here and look for findings of fibrosis in the subpleural regions, traction bronchiectasis, honeycombing. There isn't any. Looking for traction bronchiectasis in general, there isn't. It's just a relatively low profusion of reticular opacities, and then some very ill-defined, more hard to describe ground glass. So the more recent imaging shows exactly the same findings, but I'll show you the expiration series to show you that there is no air trapping. Here's some selective images for no air trapping. So I would not be able to make a diagnosis. I would just describe this as unclassifiable, certainly by virtue of the absence of subpleural traction bronchiectasis and honeycombing, or even traction bronchiectasis. I wouldn't be thinking of UIP particularly, but if anyone thinks this pattern is suggestive of a particular entity, certainly say so, but I would simply describe it as abnormal, unclassifiable, and really that's it. So let me bring up this. I'll fix that for you. And let me close this out. So here is a pattern of fibrosis. I'll just mag this up a little bit. That is an airway-centered fibrosis. So because I've seen quite a lot of these over time, I feel reasonably comfortable seeing at least the basics of interstitial lung disease fibrosis patterns. Typically with UIP, the fibrosis is peripheral in the pulmonary lobule, and it's very different from this. You have intermixed areas, a relatively normal lung and fibrotic lung, and substantial amount of distortion. Clearly, if you look at this biopsy, you can see here we have normal interalveolar septa down here, and certainly that's not at all suggestive of fibrotic NSIP. So typically the pathologist will look for, just like we do, for the pulmonary lobule, looking for the paired bronchiole and artery in the center of the pulmonary lobule. And here you can see there's some airways here. I'll make this even bigger. And this relatively deep staining cells here are respiratory epithelium. So looking for a normal bronchus. I don't see one here in the companion artery, but we're in the central portion of the pulmonary lobule. So this is sort of an airway-centered fibrosis. And what's also remarkable about this is that there is extension of the respiratory epithelium of bronchioles, certainly away from the lobular bronchus. So that's called peribronchial metaplasia, forming, and this is the description of my colleague right there, a form of airway remodeling. So let me go back to make that small and onward a bit here. So here again we have, now we can see here is a bronchus with respiratory epithelium. You can see there's a lot of pathology centered around this airway, particularly in this portion of the lobule. Here again, you can see these cells, respiratory epithelium, extending away from that bronchiole. So that is peribronchiolar metaplasia, which is what one looks for airway disease. And so let me just make that small again and get back to where I was, if I can. What I did there. Okay, so let's go back this way. And then I want to show you here that one thing pathologists look for when you see airway-centered fibrosis is this bridging fibrosis that goes across from one lobule to another. So here we have this sort of bridge of fibrosis extending from one terminal bronchiole, or rather lobular bronchiole, to another one over here. And there is a mild subpleural fibrosis, but most of it is that airway-centered fibrosis. So what is this thing called airway-centered fibrosis? This pathology has been described before, and here is one particular article. Again, this is sort of a retrospective kind of look at this kind of pathology. They described 12 patients with this form of fibrosis, and most of them had restrictive lung disease, and the pathology, again, fibrosis around large airways. And here are some differential diagnoses. Now, some of these were clinical diagnoses here, as you can see here. But one of the things nowadays that pathologists try to do is try to make distinctions between centrilobular fibrosis as a potential finding in fibrotic hypersensitivity pneumonitis. Sorry about that. I'm working without my mouse, so I'm moving around too much here. Sorry about that. Let me try and move this better. But one of the things that pathologists think about when they see this centrilobular fibrosis is the possibility of fibrotic hypersensitivity pneumonitis. So here you can see here in yellow that it may be found in other forms of fibrosis, as indicated up here as well, but typically is not a dominant finding. In fact, it argues a little bit against UIP as a cause of the fibrosis. So basically, this case is kind of unsatisfying in a way because we have this patient with this pathologic picture, She's not known to have hypersensitivity pneumonitis as far as I know based on history. She doesn't have a connective tissue disease of any type. So I don't think she has a history of aspiration. I'm looking at this table right here. But that's the pattern of fibrosis. Not something one can discern at all from the CT images. Jeff, do you have any insight? Do you ever encounter these kinds of cases where, I'm sure you have, where you have a particular picture like this and then you just have a description of the distribution of disease and that's as far as we can go?
Yeah, I mean, the peribronchial metaplasia, our pathologists, in most cases, when it's airway centered, with other findings, says it's highly suggestive of hypersensitivity pneumonitis. I think that's a very useful finding. I mean, I don't think we would have. It's unusual to get a biopsy of a case like this because usually it's so mild, nobody's going to biopsy it.
Yeah,
Um,
I'm not sure how
and
that,
so maybe we're just catching it very early, but
yeah. Yeah, I mean, there's a lot of debate in the pathology community, even about the entity of fibrotic hypersensitivity pneumonitis, how to make the diagnosis. But certainly they
mhm.
look for airway-centered fibrosis, in particular, one of the things, in addition to things like poorly formed granulomas. And certainly one of the things that we look for sure, is a pattern of fibrosis. Well, this
Yeah,
is really a
I,
mild case, but we look for
yeah, I
air traffic.
suspect this patient may be chronically aspirating as well because there's bronchiectasis in the lower lobes away from the fibrosis and that big hiatal hernia. Who knows how that plays in? But there's more than just traction bronchiectasis. If you go like a little more centrally, those posterior basal bronchi are a little too big.
He's here.
Yeah, even further up.
Very mild, if
Yeah, it's very,
normal.
very mild. So, but I don't think that accounts for everything.
Yeah.
The other thing to
So
always think about with these patients is I mean, it seems like HP and connective tissue disease are always in the same histologic and sometimes radiologic differential diagnosis. But luckily, we can mostly test for autoimmune disease pretty well these days.
yeah.
It's
So
interesting.
I'm not
The
sure,
pathology can be
how
very.
they get this patient. They probably, at least in part, and I don't know what a pulmonary function tests are, but they'll probably image her after a couple months, for example, to see how things are progressing. And perhaps if there are findings of progression, it's likely that they may treat her with the drug nintedanib, which supposedly has some efficacy in progressive pulmonary fibrosis other than UIP. So that kind of workup may be in her future, maybe a period of observation and then re-image looking for progressive pulmonary fibrosis. Yeah.
Okay, well, thank you.
Okay, that's my case
All
for the
right.
week.
Shrav said he has a case.
It's going to be the UCSF fax.
So I
Oh,
presume that's the one with the no audio.
that is the one with no audio. Yeah.
All right, so hopefully I picked the right one.
Okay. Can everybody see the screen?
Yes.
Sounds good. So this is a fun exam. This patient came in with some coronary artery disease-like symptoms. He was having angina and presented for a coronary CTA. So if we take a look at the scout image here, we can see that his left lung is somewhat asymmetrically small. The mediastinal structures are shifted over to the left. And we take a look at his coronary CTA. As we come up here, notice there's a fairly large vessel coursing along the undersurface of the left hemidiaphragm, and then there's some branches that are kind of going into that left, along the left aspect of the heart. And we keep coming farther up. I'll ask you to take a look at the RCA. We have some interesting anatomy here. So a branch comes off of the RCA, and we'll kind of follow it as it takes this retroaortic course and comes back here and there's several small tortuous branches right here, and eventually this kind of goes towards the left hilum. And I'll just stop right about here. And if we take a look at the pulmonary artery, you'll see that it looks odd. There's no left pulmonary artery in this case. So this is a congenital absence of the left pulmonary artery, and the left lung is being partially supplied by a branch of the RCA, and that presumably that's what's causing this guy's symptoms. And he may be, there may be some coronary steal going on because the left lung is kind of taking some of the circulation, some of the flow from the right coronary system. And then, of course, he has poor inflow to the left lung, and so his outflow is also not that great. We have with some contrast mixing here in the left atrium. Just thought this was pretty interesting case, not something we see every day on coronary CTA for angina. So nice case.
That's really cool.
Yeah.
What does the
Yeah.
what does the lung parenchyma look like?
Yeah. So if we take a look, it's kind of a little bit of
If you look along the fissures, you see a bunch of what look like nodules, but I think those are a bunch of transpleural collaterals.
Yeah, probably. And put it back here. Yeah, they're really tiny, but there's lots of little vessels along here.
Yeah.
So yeah, interesting.
Yeah, no, we've seen cases of typically, of course, we talk about bronchial artery supply with proximal interruption, but we've shown cases like this where the arteries involved come from the coronary arteries, other vessels, upper abdomen. I'm not sure if I've seen one of those, but I have seen, like your case, vessels coming off coronary arteries and going to the affected lung. So I don't know if I've ever seen a case in which there is thought to be an actual steal phenomenon sufficient to produce symptoms. Wow, I wonder.
Looking at the rest of his coronary arteries, they were clear. He doesn't have any significant stenosis. So, I don't know if his symptoms are because of something going on in the left lung or if they're related to this at all.
Yeah, very nice case of proximal interruption.
Yeah.
Right. Let's see, David, you're on. Do you have any cases this week?
You.
All right. Oops. Let's see. View control here.
Can people see a radiograph, one hopes?
Yes.
Good.
Okay, this person has a mediastinal mass. You can see it bulging here, just below the aortic arch. And on lateral, kind of hard to tell, but there's a lot of whiteness up here, a lot of overlap. So this is probably where it is. So it looks as if it's anterior. And it was CT'd. And indeed, there is a mass in the upper mediastinum. It has a little bit of calcium in it, has some lowish attenuation in it. And at the top seems to disappear, so it's fairly discrete. So it's fairly firm looking. It looks firmer than a thymoma. It's bulging against the mediastinal contour here. So I don't know. What do you think?
Still could be a thymoma. Calcium, not common in thymoma, but I think that can happen.
Yeah, thymoma. I think about 20% of thymomas will have calcium. The cystic stuff's a little unusual, but does occur. Maybe ectopic thyroid tissue. It's kind of dense, so that might fit with ectopic thyroid.
Okay.
And then
doesn't seem to communicate with a thyroid gland.
Right, but I would say if it's ectopic as opposed to a direct extension, because it looks about the same attenuation as the thyroid.
Okay. So eventually this person had a contrast study for follow-up, and the thing enhances like crazy. Then I noticed
Oof.
that there are some fat vessels nearby seem to be going into this thing.
How about a paraganglioma?
You know, so the
Paraganglioma is a
I'm sorry, what?
thought.
What about a
Yeah,
germ cell tumor?
paraganglioma. Um, that enhancing, don't
Yeah, I've never
think
seen a germ
so.
cell tumor enhance this much. You guys agree?
I mean, the one I think about
Unicentric,
that,
yeah,
yeah, paraganglioma is
unicentric,
one.
yeah,
PR
What?
Castleman.
unicentric Castleman can be very enhancing. Calcification, I'm not sure about. The ones that I've seen that are unicentric Castleman typically don't have areas of low attenuation within. They are just homogeneously very attenuating. Be
Okay.
a very unusual location for a neural tumor of some type.
Okay.
Paraganglioma.
Okay. So top choice paraganglioma or
I like paraganglioma.
Yep,
okay.
that's where I'd put my money, just based on
Okay.
the imaging.
So they popped it out, and Jeff was right at the beginning. It's ectopic thyroid.
Oh,
So
really?
very enhancing. And if we go back up to the thyroid gland here with contrast, you can see that the thyroid gland loves to enhance with contrast. It's very vascular. It's not just the thyroid uptake of iodine at this point. It's really just the vascularity that makes it blush so much. And so here's ectopic thyroid in the chest. Because of the low attenuation components to this thing, people had in mind that this was a germ cell tumor. But if you look at the attenuation of those lowish attenuation things, it's not really fat that we're seeing here. It's this is like 20 or 30 Hounsfield units, so it's lowish, but it's thyroid likes to have collections of colloid and stuff like that in it, so it's very handy for the thyroid's allowed to have low attenuation elements to it. It's also allowed to calcify. So if we could see a connection of this to the thyroid in the neck, we would say, well, this is just a goiter based on these imaging characteristics, including the strong enhancement. And I think that the fact that it's vascular tissue is why we do see some hefty arteries. The paragangliomas I've seen have had even fatter vessels than this, though. So these are abnormal. These are slightly dilated vessels, but not compared to what you can see in some cases of paraganglioma. So I think thyroid was a great idea, and ectopic thyroid, we don't see it that often, but here it is. So
Dave, can you put
cool.
the non-contrast alongside that? Because initially I wasn't personally impressed by the attenuation of it on the non-contrast
So
on
you can
my
see it's
display.
lowish. It's lowish, but it's not fat, and it doesn't look like uh, degraded hair, um, collagen from hair forming in a germ cell tumor. It's higher attenuation than that. I think it was like 20 or 30 Hounsfield units. So ectopic thyroid, it's on the list of anterior
Nice.
mediastinal things that enhance. So good discussion.
Great.
So I hope you can see a fresh radiograph here. This is a person who presented with fever and cough and has consolidation in the left lower lobe. You can see it better on the frontal radiograph, obscuring the descending aorta, than you can on the lateral, but it's lurking back here. So it doesn't occupy the entire left lower lobe, but there is this increased whiteness here, giving us a little bit of a spine sign back here. So this woman was treated for infection, and this lesion persisted, and she had a CT scan. Um, Again, this is all outside with this stuff in her left lower lobe, some airways getting into it. And then she got a PET scan, and it lit up a little bit around the edges, but not a whole lot. So it did light up some, even I think a month out from her initial infection. And then ultimately, and then she got a needle biopsy. So ultimately, she had a contrast CT scan, and it all comes clear because as we go down, there's a big honking artery coming off the aorta going into this lowish attenuation lesion down here, and this is a sequestration. So the findings aren't all that clear cut on the earlier imaging. It's only the contrast study, I think, that really enables you to nail the sequestration as the cause of this cystic mass down here. And it was infected. And so once things cooled off, this lesion has been resected, but only with contrast here and picking up the congenitally placed artery can we identify this as sequestration. So if they'd given contrast at the beginning, they could have cut out a whole big workup, including, needle biopsies and a PET CT scan.
Yeah, really.
Yeah. And this person also has a lesion in the left base with a pleural effusion as part of it. Let me show you the scout view first of all. You can see there's quite a bit of stuff in this left lower lung down here, or left lower thorax, some pleural effusion as well. So on CT cross sections, we come down, there's some mediastinal calcifications, likely from histo or something, and then there's this big mass down here, really big mass, inhomogeneous, accompanying pleural effusion. And it's hard to tell where it is arising. Its upper extent is kind of pushing into the mediastinum, or maybe pushing the esophagus off to the side there, and goes all the way down to the diaphragm. And this was, let me show you coronals here, quite a big mass. This was a solitary fibrous tumor. At this stage, it's not been resected. It has been needle biopsied, and it's benign on the basis of the needle biopsy. There is not an excessive number of mitoses. I guess the cells are fairly uniform. On the biopsy, they didn't find any necrosis, but the biopsy is just a small sample, and it looks to me as if there probably is some necrosis given the low attenuation components to this thing. So inhomogeneity and pleural effusions are signs that make you worry that this could be one of the malignant versions of solitary fibrous tumor. So far, we don't have that, but when this lesion is finally resected, then we'll have more tissue to look at, and they can look harder to see if there are any signs of malignancy in parts of this lesion. So a very large solitary fibrous tumor. I presume it's coming off the bottom of the lower lobe. That's where they tend to arise. They like to hang off the bottom of the lower lobe. They do arise from visceral pleura of the lung. So my best guess, just based on the notion that they like to come off the bottom of the lung, is that this is coming off the bottom of the left lung, and you can see it's indenting the diaphragm back here. It's so big. Okay, so a very big SFT. At this point, presumed benign, but surgery to follow. And finally, this person came in with abdominal pain and has a bunch of dilated gut here. Most of this is small bowel. This is definitely small bowel here. A little hard to tell what's going across here. This is the course of transverse colon, so it could be that. We do have a bubble here that's kind of higher than the right hemidiaphragm on this side. And this person is having a lot of pain and has leukocytosis and had CT. So CT is confusing. We do see pleural effusion down here. We see a very cruddy base. We've got some gut here. It's kind of hard to tell where the gut is. Coronal is a lot more revealing. because we see that we have very dilated small bowel loops, and some of those small bowel loops cross the diaphragm into the chest. Here you can see stuff up here and small bowel. So this was a severely obstructed small bowel. Now, if we look at the course of the diaphragm, we see that there's this bright material here, and it turns out that this person had a congenital diaphragmatic hernia that was repaired with a mesh graft. So this is probably a piece of Gore-Tex here, and Gore-Tex is bright when it's been in the body for a while. Initially, you can actually see sort of air density associated with the Gore-Tex when it's first installed because it traps a lot of air. And then the mesh fills with fluid and then becomes dense. So we have this density here. So we have this disrupted mesh graft from a previous repair. Now I was looking through the notes, and people were operating. They operated on this person very quickly because this person was very compromised because of the small bowel obstruction. And the history was not very clear as to when this surgery was performed. This person is in 20s age range, and so this could have been done much earlier. It could have been done 10 years ago, or maybe it's a recent thing, but that was not clear from the notes, at least to this point. So this person has now had this hernia reduced. I don't know whether they had to resect any small bowel in doing that, and is now recovering. So congenital hernia, and then failure of the mesh graft, and new herniation with small bowel obstruction.
Very
Okay.
nice case. Yeah.
Yeah.
I've got one just like that. I think I showed some years back, also with the identical history, repair of a hernia in childhood, not using mesh though, but just repair of a hernia with later presentation just like this.
Yeah. Okay. Thanks, guys.
Excellent. Thank you.
Thanks, David. Alrighty, I got some cases I can share now. All right, so you should see a CT.
Good.
So this first case was a lung cancer screening CT, and there's several interesting findings. So the first I'm going to bring to your attention is the posterior basal right lower lobe. You can see there's this large vessel here that runs along the pleural surface and goes towards the corner here, and you'll see that the vessels around it are larger and the lung attenuation is denser than the remaining mostly emphysematous lung. If we change the windows, you'll see that there's calcium in it, so there's some atherosclerosis. And you can see it looks like it's trying to come from the aorta here. There happened to be an old abdominal CT that confirms that this is indeed a systemic artery coming off the aorta and sliding into the right lower lobe. So you might think about sequestration because we have systemic arterial supply, but if you look at the lung parenchyma, there's no sequestered lung. It's just hyperperfused. So this is just systemic arterial supply of the lung. But when there's one congenital thing, as you know, there's frequently another. So the next interesting finding is if we look at the soft tissues, you'll see there's this large pulmonary vein coming into the left atrium, and that is the only pulmonary vein coming into the left atrium. So it is a single pulmonary vein draining the entire right lung. And the other interesting thing is if I show you the coronals, you'll notice the relationship of the bronchi to the pulmonary arteries. They're both hyparterial bronchi. So these are two left lungs. So this is left pulmonary isomerism. There's a hint of a fissure on the right, but not really. So it's a bilobed lung. The abdominal side is normal, and there's no polysplenia. So this is isolated to the chest. So we have left pulmonary isomerism, we have a single pulmonary vein, and we have systemic arterial supply, all just instantly found at lung cancer screening. And it's kind of cool that there's atherosclerosis in this, probably because this patient was older, 70s, so high flow, high pressure flow for many years. All
Very
right.
nice.
So even in younger people, you can see that calcification of the systemic artery in cases of sequestration, again because it's getting systemic pressures.
Yeah. Yeah. I don't recall. I don't
So
know. I've not. I've seen it a few times, but I always recall the patients being a little older. But that's good to know.
yeah,
So this was a
it's called premature atherosclerosis of the artery because of that.
yeah, makes sense. So here's sort of a companionish case, which I have a nice radiograph, but to be honest, the finding was more of a retrospective observation. So um, nothing terribly exciting, except we have nice anomalous drainage of the left upper lobe here into the brachiocephalic vein. But you see this nice big artery. But what was kind of cool is you can kind of make it out on the chest radiograph. Um, Here's the vessel here. It's kind of hiding behind the the rib here, but the lateral I thought was quite nice. And you can talk me out of it if you think I'm making it up, but I think this is the vessel right here. We're looking down the barrel of it. If I do
Yeah,
the
Yeah,
bring
yeah.
the CT
cool.
back, we'll make a sagittal, and then we'll do a average intensity projection and thicken this up. Yeah, we can see there's the vessel right there. You can see it right there. So if I put that up with the lateral, you can see there it is. So
Oh, that's cool.
every time I see this, I always go back to the radiograph to see if I can find it. I think the only time I've called it prospectively was when there was a catheter in it. That was it. All right. So those are the congenital ones. This is just an impressive case. This patient presented with this large mass. If you look at it, you might think it's centered on the mediastinum, but it's actually centered up a little higher and a little more anterior. So we notice we're at the clavicles here. There should be manubrium, and there's no manubrium, but there are little calcific fragments within this mass, which should help inform the diagnosis. Here's the sagittal right here. So when things get real big, of course, it can be hard to figure out where they come from. But I think the presence of this matrix in here is very helpful. This is, I think, the largest or the second largest chondrosarcoma of the chest wall that I have encountered there. And clearly it's dedifferentiated because it has cystic components, and then the intrathoracic component is really lacking that matrix. I showed one a while back, I think it was last year, that had two, it was like a biphasic tumor. One clearly had tons of matrix and one part had no matrix. And so when they dedifferentiate, become more aggressive, you tend to lose the matrix. So just a really big chondrosarcoma, and of course it looks like it's metastasized to this lymph node here and extends all the way up outside the field of view. So massive chondrosarcoma.
One wonders if the patient, if there's a backstory about such a late, seemingly a very late presentation for a very large, presumably
Yeah, I
painful.
mean, I've seen
Hmm.
several really large chest wall tumors, and you just wonder if there's some psychological denial or maybe other social things.
Yeah.
So this was just kind of an odd case. It's a good case for trainees. We're always looking at positioning of catheters, but I don't recall ever seeing this one and how they managed to do this. This patient has a pulmonary artery catheter that takes this very odd route here. But then it comes out through the RV outflow tract, right pulmonary artery, goes into the interlobar, and then somehow loops back on itself and comes all the way back towards the main pulmonary artery. And I just can't figure out how they looped this within a vessel, because these usually have a curve in them, and they're not so floppy like a pick where they just float around. I don't know. Has any of you ever seen? I've seen them go out in different branches, but I've never seen one fold back on itself to this extent, unless there was some underlying stenosis, which I don't think there was. I would have thought at most you would dissect the pulmonary artery or do something, but it was unclear how they managed to get this catheter in this position.
Gosh, yeah. Can I take
All
a
right.
guess that the patient is a heart transplant recipient? And if I'm correct, I'll say why. Do you
Yes,
perhaps
because
know?
there's all the sternal wires, yet there's no anything else.
No, there's another finding there. If you look in the left axilla,
Oh, the tie
um,
down, yes, from the old
yeah,
defibrillator,
there are
yes.
two suture sleeves there. So the patient prior to surgery undoubtedly had a pacemaker device, maybe a
Hmm.
CRTD device. And of course, they remove that, but they don't always remove every component of it. So we're left with 2 left pectoral suture sleeves that they just left behind in that location. That's kind of a little telltale sign that there used to be a pacemaker there. But yeah, that
For
catheter is
sure.
very impressive. Yeah.
So, Jeff, it is indeed a heart transplant person you're confirming.
It is. Yes.
Maybe that's the reason that this thing. So, presumably, I mean, in order to get these loops like this, the catheter doesn't go out into that interlobar right pulmonary artery and then turn around abruptly, make a hairpin turn, and come back. That would be physically impossible. What happened
Right.
is that
Right.
as you were feeding it, it snagged where you see the tip, and then they pushed, or something that's hard to push on these catheters, but they they may had a really strong intern. So what happened was from the snagging point, it formed a loop, and as it pushed, the loop went out. So it's the loop was threaded out into that interlobar pulmonary artery.
That makes more sense, and I wonder if that's why there's a bend in here too, and maybe was under pressure at the time because they kept trying to feed it.
Yeah. So and maybe the snag was promoted by maybe an anastomosis between the native and the transplanted pulmonary artery or something like that. Maybe
Which
there
would
was
be
a
right
little bit
here.
of maybe a little bit of a ledge there or something like that that it snagged it.
That's a great idea. Yeah, that would be right here where the tip is. That makes perfect sense. Yeah, because these things are pretty stiff. It's hard to, I don't know how they would bend it on itself. So that makes a lot more
Yeah.
sense, and that would explain this
It's
funny
this
course
it's the
here
same
as
thing
well.
with the enteric tubes that go down the esophagus, turn around and head back up to the neck. You know,
Hmm.
they snagged on the way down, and then as they push, they just push the loop out ahead.
Good thought.
Cool. I
Yeah.
like that. Makes much more sense now to me. Good. I like that. All right. This was a de novo case. I like this one. So this patient carries a history of myalgia rheumatica, and has been for years and has intermittent areas of pain and swelling, and then recently had a bunch of elevated inflammatory markers. And this patient's rheumatologist actually, I think, was all over this diagnosis before we had imaging, and noticed the patient had developed a saddle nose deformity, which the patient was even unaware of. So did the CT looking for signs of autoimmune disease. And what's interesting is we look at and it's not the most severe case, but if you notice already looking at the airway, it's abnormal. The posterior membrane is nice and thin, but the cartilaginous portion of this trachea it's too thick already. This is not a normal looking trachea, and there are some calcifications just kind of scattered throughout, but it consistently spares that posterior membrane. And then if we go out to the carina, it gets so thin back here. This is always my favorite place to look for membrane because it's so thin and you get air on both sides of it. But you can see that the bronchus intermedius is thick and narrowed. The origin of the middle lobe is really tight here. And then this goes out a little bit and then it sort of fades out. And that was really the only abnormality, but this is pretty classic for relapsing polychondritis. And in retrospect, the patient had complained of some intermittent ear swelling and redness, and has the right HLA type. I always forget which one it is, and a lot of really elevated inflammatory markers. So this is the initial presentation of relapsing polychondritis with abnormal trachea, but it's on the milder side with this degree of thickening, but sparing that posterior membrane. So that was kind of a fun case.
Well, Jeff, does that
Yeah.
go with PMR? Is that
I don't know. PMR seems to go with everything these days. Just some sort of autoimmune stuff, but I'm not
how
aware of
how
a
old a
direct.
person is this?
Older, 77 or 76.
That's a good age for PMR, but it's not the world's best age for relapsing polychondritis. So
Yeah, no, I mean, I haven't seen a ton of cases because it's pretty rare, but the last patient I saw was in his 60s. So, but he had
really,
had it for at
okay.
least a decade. Yeah, it usually presents more middle age, but yeah, so who knows how long she had this for, but it hasn't caused a ton of problems. She does have some respiratory symptoms, and you can see she does have a little bit of bronchiectasis, which may or may not be related. It's just, I mean, very modest. some dilated airways in the middle lobes. The middle lobe was pretty tight, so she's got a little bit of mucus there and a little bit of bronchiectasis. So it may have been brewing for a while. It's just now declaring itself. And she may have been on enough medication for her PMR that it was sort of suppressed a little bit. All right. This last case is another just really nice example of, let me get these on the right one. Yeah, so this patient was referred to us for their ILD, and back a year or two ago, actually at this time, had developed a spontaneous pneumothorax. You can see it hiding here in front of all this stuff in the lungs. But if you look at the lungs, there's all these large cystic spaces, and as we go down, you can see they get quite large and a high profusion of them. So a nice example of what's been called exuberant honeycombing. I personally am not convinced it's truly honeycombing as what we see with the typical UIP, but it is these confluent cystic spaces. And you'll notice back here, they're already sort of sharing some walls and becoming these larger cystic spaces. And then on the follow-up one, it's progressed, but what's interesting is some of these up top, for example, these guys in the right apex have sort of collapsed down. And then if we go to the bases, that confluent space I showed you has really kind of filled out even more, I think, like where you see immediately here, these smaller cysts. So I've not seen them coalesce so much in the past. We usually don't have don't necessarily have a lot of imaging on them, but this patient I had at least I think it was an 18-month time frame between the two. But I've not. That's one thing I've not noticed was the coalescence of these cystic spaces forming this really large space down here. But when we see this exuberant honeycombing, it's highly suggestive of connective tissue disease, particularly rheumatoid arthritis, which this patient has. Although I just saw one today in a patient with scleroderma that has not quite to this degree, but has what we would call exuberant honeycombing. But earlier on had more of a sort of a mild NSIP look that developed these cystic spaces subsequently. Maybe I'll try to get that one for next week. But have any of you ever noticed the sort of this coalescence of these large cystic spaces?
I haven't seen one this severe and that coalescence.
Mm-hmm.
This is remarkable. Yeah.
Yeah,
I've seen this exuberant honeycombing with a sort of mid and upper lung predominance along fissures and things like that in people with sarcoid.
Yes.
So, and I think Ton has shared some cases like that in the past that also had that finding.
Yeah.
So
yeah, I have one sarcoid case like that, but it looks almost more like paraseptal emphysema. This
right.
is clearly not, but I don't know. But we call it exuberant honeycombing, but I don't think it's the same thing because those honeycomb cysts with UIP are small, they're thicker walled, and they don't get this big. So I think this is a different process, but of course we don't biopsy these patients, so we have no idea what's really going on.
You know, we were discussing this phenomenon about 10 or 15 years ago, you and I and some others in the conference, and for a while we were talking about this being pseudo honeycombing, and we had a case then that our pathologist looked at, and he said, "This is not honeycombing. This is a kind of emphysema because of the thinness of the wall. There wasn't the fibrotic process. There weren't fibrotic capsules around the holes the way there is with real honeycombing." So he really said he was seeing emphysema. And, you know, these findings sure look like emphysema, particularly the merging of those big cysts into these larger collections.
Right. You know, and sometimes we've seen those patients with a smoking-related ILD that get this kind of phenomena, usually in the posterior lower lobes, this so-called airspace expansion with fibrosis.
Yeah,
and I wonder if indeed this is what this is.
Yeah.
Because if you look elsewhere in this patient, I mean, there's it's this denser fibrosis, but it's not your typical UIP reticulation type fibrosis that you typically associate with rheumatoid arthritis. I think it's a different pattern. So anyway, those are my cases for this week. We had some good cases, and it's just about the hour. I don't think anyone else joined us, so we'll call it a day.
Thanks, everyone.
Yep. Take care.
Thank you. Bye, everyone.
Bye-bye.